Hello, good evening to all. Am I audible? Can somebody confirm? Jeevan, am I audible?
Yes, sir, you're audible.
Good evening to all once again. This is our Friday classes, usually 6 to 7 p.m. By the name Fabulous Friday. And today we are going to discuss about trauma scoring systems. And my main focus in this class will be not to tell you about why do we use scoring system, how do we use, not much about that, but more about the common score is the most common score for injury specifically which you are using is the injury severity score and the new injury severity score. So how do we actually calculate these scores? So I will be teaching you this, and it will be an interactive class. So initially 15-16 slide will be there where we will be talking about the theory, and then we will be just verbally discussing with each other, like if such an injury occur, how you will score it. Then in the last you have to participate. So this will be the goal of today's class. And so we start here. So what is the need of scoring system? It is to standardize the injury description first. Then we can rank the injury severity, like based upon some scoring system, we can rank the injury severity. Then we can do the risk at first is we can standardize, then we can do the ranking of injury severity, then we can risk adjustment for comparison of outcome. Like if you have to compare two femur fracture, then we should know a femur fracture of shaft, a femur fracture, closed femur fracture versus an open femur fracture. If there is change, what is the outcome? So we have to know what is the injury of both the patients. Then we can predict the probability of survival depending on how much severely injured one patient is. And then we can do the functional impairment or the disability assessment in this patient. And basically whenever you do some kind of studies, then you need a definitive answer, like how much injured your patient was, to compare in the two groups. So that's why these scoring system are kind of a mandatory if you're learning something in trauma. So what will be an ideal scoring system? This is goes for every scoring system, which to serve the purpose of quality improvement, an ideal score must have following factors. One, it should give us the status of the severity of injury. Secondly, it should enroll in itself some physiological derangements. Then patient demographics, mechanism of injury, and comorbid condition. If all these are involved in one scoring, that will be kind of a ideal scoring system. Just once. Sorry. So patient outcome will depend upon anatomical injury of the patient, what were the patient physiological score after the injury, and what are the patient's reserve. So this will tell us about the Jeevan. Excuse me, Jeevan.
Yes, sir.
If I can make you host, can you mute the participant who speak in between? Will you help in that?
Okay, sir. Okay, sir.
I will make you an co-host, and then you can mute. Okay.
All
Just
right.
give us 5 minutes, please. Okay, we start our class again. So this will be an ideal scoring system, which will have, so the outcome of patient will depend upon what is the anatomical injury patient has, what are the physiological reserve of the patient, and what are the physiological score and what is the patient reserves. So to enroll, we have tried multiple systems. So what currently system we have with us are few anatomical scores we have, then few physiological scoring system we have, and few combined scoring system we have. So anatomical scoring system which we currently have and which are in use are basically abbreviated injury scale. So this scale is basically tells you about the anatomical injury, then injury severity score, and then ICD-9 injury severity score, which is ICISS. So these are the anatomical scoring systems. Then coming to physiological scoring system is one which you are very commonly using is the Glasgow Coma Scale, and one other variation of this is Glasgow Coma Scale Pupillary Reactivity Score. So GCSP goes by this name. Then we have revised trauma scores, and then we have Apache score. So Apache is basically for ICU patients, and for mostly the non-trauma patient we have Apache scores. Then combined score have both some or other combination of both anatomical, physiological, as well as the reserves of the patient. And these include TRIS. This is the most common, and it is mostly used in for research purpose only. This is trauma and injury severity score. And then we have one Ascot score. So this is a score of characteristics of trauma. And then you have trauma index. So these are the score which is the combined scores available to us. So coming to the first anatomical score is the abbreviated injury scale. So it was first published by Advancement of Automotive Medicine. So this AAM is one organization, and this has every 4 yearly they update their manual, like for every injury what score we have to give. Suppose there is a femur fracture, then what score will be there? Suppose the femur fracture is open, then what will the score? If the femur fracture is closed, what will the score? If the femur fracture is associated with more than 20% of blood loss, then what will the score? If femur neck is fractured, then what will the score? If the shaft is fractured, then what will the score? So for every minute to minute detail which you can think of, even in the carpal fracture, the phalanx fracture, the skin loss of 10%, 20%, burn in head injury, there are scalp fracture, contusions, EDH, SDH. For every smallest detail, they give you one score. So if I am having a contusion of, suppose my patient is having a contusion of 25 ml, then I will score one fixed value, and you will also score the same fixed value seeing their diary. So this is how abbreviated injury score is developed, and this is done by Advanced Automotive Medicine. If any one of you are interested, then obviously you can go and attend their classes. They have regular classes, a regular batch, and then in the end they will give you their manual also, like how you can do abbreviated injury for each and every injuries. So this is the why I'm emphasizing on this so much is that abbreviated injury scale is basic scale, and using this AIS scale we developed ISS, NISS, and then even TRIS score, ESCOT score. Every scale has component of this. Until you know what injury you will give to, what score you will give to one single injury, you cannot advance further. So this is the most basic abbreviated injury scale you should be knowing. Secondly, it rates the severity of tissue damage secondary to motor vehicle crash. It provides a standardized terminology to describe injuries. So what they did is this AIS by arm divided the body into 9 different regions, which are head, face, neck, thorax, spine, abdominal and pelvis region, upper extremity, lower extremity, and unspecified. For each body region, like for head they have one chapter, then for face they have one chapter, neck they have one chapter. So this is how they are teaching us. This is how they have classified their injury scales based on this. But this is not, it is something different from ISS. So you do not have to remember this. This is just to tell you that they have done it, but you don't have to remember. So forget about this, whatever they are telling. You just remember how they are going to classify each and every injury. So in the short AIS, It is a consensus-derived, evidence-based global severity scoring system that classify each injury by body region according to its relative importance on a 6-point ordinal scale. So I hope you all know what is an ordinal scale. Ordinal scale is when you divide injury into some categories, but category 1, difference between category 1 and category 2 is not similar to what is the difference between category 5 and category 6. So the difference can be separate. So 1 to 2, if one patient goes from an injury of 1 to 2 and another patient goes from injury 4 to 5, it does not mean that they have equally progressed or decreased, vice versa. So this is the meaning of ordinal scale, and it is developed for grading injuries. So AISA reflects severity of single injury only. This is to emphasize, for single injury, one AIS will be given, and it is unaffected by time, sequel, and outcome. So why it is important to understand is, see, when trauma has occurred, one patient has developed a parietal bone fracture or a humerus fracture. Over the time, you will see humerus will heal or will go into non-heal. It may get infected. Patient may land up into sepsis. But the AIS score for that particular patient will be same throughout the time. It is non-affected by time. So for every injury, only one score can be given, and it will be given based on what initial injury has occurred, not the sequel of it. Why I'm telling you is that, suppose femur fractures occurred. Initially, the blood loss was less than 20%, but later on, while they were operating, the blood loss has increased to 40%. So it does not mean that initially you give the femur fracture the score of 3, now you will change the score to 4. So it will not change, it will remain 3. And this is again to emphasize, when the patient comes to us for repetitive surgery, his AIS score will not change over the time. His physiological score can change, his physiological reserves can change, but his AIS score will remain same, even if the injury is healed or non-healed, or any sequel has come, or the patient had died, still the AIS will remain same. So the skill 6-point ordinal scale given by them is 1, 2, 3, 4, 5, 6, and 1 means minor injury, 2 means moderate injury, 3 means serious injury, 4 means severe injury. So there is a difference between 3 and 4. 3 is serious, 4 is severe, 5 is critical, and 6 is maximum. So this is how they have divided grossly: 1, 2, 3, 4, 5, 6. This is the ordinal scale which you will give to each injury, and not just the text of it is just that it is minor, moderate, serious, severe, critical, and maximum. But the problem with AIS is that it fails to account for cumulative effect of injury. Suppose patient has had 3 fracture, so you will give injury to one, like AIS to femur fracture, humerus fracture, and radius fracture you will give, but the cumulative effect is not given to us by the AIS. Only for one particular injury, one score will be given, and it has a non-linear relationship between maximum AIS and mortality. What is the meaning of is that, for maximum AIS, suppose coming back to my previous slide, if the score is 6, it does not mean as everybody will have mortality, compared to vis-a-vis if the score, if the patient has 2 injury of 4 for severe 4 severe injury, he may have more mortality compared to when he has a single injury of 6 or 5. So this is the means that there is non-linear relationship between maximum AIS and mortality. So summation of AIS score is inadequate. Suppose AIS, one patient is having a injury, suppose a femur fracture, which is having a blood loss of more than 20%. So for that, the AIS score will be 4. And he is also having a humerus fracture, which is open fracture. So the AIS given is 3. For in this patient, the mortality can be 24%. But you see the total score is 7 only. 4 plus 3 is 7. Again, a next patient who is having a very large EDH, and his for head injury, the AIS score again is 5. And he's also having some skin laceration. And for that, AIS given is 2. In this also, the total score will be 7. 4 plus 3, 7, 5 plus 2, 7. But the mortality will be higher in this patient. So you only by summation, you cannot tell how much mortality he is like to having. So these are the limitation of this AS score. For to solve this purpose, Baker et al. In 1974 proposed a injury severity score, and it is an algorithm based on AS. So this is the scale is basically depending upon AS score, and it is designed to improve the ability to predict the mortality. So first you understood what is AS, then seeing this AS by Baker et al., a new score of ISS is developed to predict the mortality. So what is injury severity score? So according to injury severity score, the body is divided into 6 regions. So for all of you, for the practical purpose, you have to remember this 6 body region, not what AS is given as 9 regions. Don't remember those. Remember this 6 body region. So body is divided into 6 body region. First is the head and neck region. Second is the face. Third is the chest. Fourth is the abdomen and pelvic content. Only the pelvic organ like uterus, the bladder, the rectum, only the pelvic content, not the pelvic bone. Extremity and pelvic girdle are a different body region, and external is different body region. External include your skin only. So according to injury severity score, the body is divided into 6 different regions. Now you will ask me about the spine. One thing is missing in this is the spine. So if cervical spine is there, it will be counted into head and neck region. If thoracic spine injury is there, it will be counted into chest region. If lumbar spine is injured, it will be counted to abdomen and pelvic content, and obviously then extremity. And if the skin is injured, then it will into the external. But suppose there is some fracture and the overlying skin is injured. So suppose there is a 3B fracture and the skin injury is 5 to 10 centimeter over the fracture, then this external injury will skin injury will not be counted into external, rather it will be part of extremity only. But if suppose the patient is not having any fracture, he is just having degloving injury, then it will be counted into external injury. I hope you got my point. This 6 body region you have to remember, and based on 6 body region only you will be able to calculate ISS. Okay, then how do we calculate IS? So ISS is nothing but the sum of square of 3 highest AIS severity in each of the 3 most injury separate body regions. Suppose a patient is having head and neck injury, then he is having abdomen and pelvic content injury, and he is having extremity injury. Just for an example, he is having an EDH, he is having a liver laceration, and he is having a fibula fracture. So he is having injury into different body regions. So what you will do is, from these body regions, you will get maximum score. For suppose EDH, the score is given as 4. For liver laceration grade 2, the score given is 3. For extremity, score given is 2. So what you will do, 4 square plus 3 square plus 2 square. So it will be 16 plus 9 plus 4. So it will be 16 plus 9 is 25 plus 4 is 20. 16 plus 9, 25 plus 4 is 29. So for that particular patient, 29 score will be there. Again, coming to a similar patient, he is having EDH, but along with the EDH, he is also having acute SDH. So for this, his AS will be, for EDH, the AS will be 4. For SDH, the AS will be 2. But additionally, he is having liver laceration of grade spleen laceration of grade 2, which the AIS is 3, and extremity fibula fracture grade 2. Now he is having 4 injuries. But what you will do, for one body region, you only have to select one injury only. Either you can select EDH or you can select SDH. But what we'll do, we will use the maximum injury. So for head and neck region, whatever the maximum injury he has sustained, we will select from one in head and neck, another from abdomen and pelvic content, and another from extremity. So these 3 injury we will select, we'll square them, and then we'll add them. So this is, we will get injury severity score. By this we will get A square plus B square plus C square. Okay. So as I have told you, for each body region, for body A region, body B or C, we can give injury from 1 to 6. Like for every AS, we can, for head and neck, for every injury, you can scale on an ordinal scale of 1 to 6, you can give. If any body region is having an injury severity of 6, which is maximum injury, then automatically the total IS will be given 75. Then you do not have to calculate A square plus B square plus C square. Then this calculation will not be done. If any body region is having an injury of 6, then total score will be 75. Okay, because and the total score range from 1 to 75. If any region having a non-survival injury, means a injury of 6, the ISS will be automatically given as 75. But if a patient dies because of the injury, it does not mean that he had an injury of 6. Suppose you have received one patient has died into the trials, you will not give him an injury severity score of 75. This is not to be done. You have to specify the injury. Like for injury 6, the score will be 75, although it is non-survival injury, but patient may survive. Every patient who is dying does not mean he has injury severity score of 75. This is to clarify. Okay. Then based upon 1 to 75, ISS injury severity score can be subcategorized as minor, moderate, severe, and very severe. For minor, the ISS score will be 1 to 8. For moderate, it will be 9 to 15. For severe, it will be 16 to 24. For very severe, it will be more than 25. So how IS is going to help us? It reduces the greater variability of injury pattern to a smaller range that can be used in outcome research. It correlates well with the mortality, but with non-linear relationship again. And it is valid for blunt and penitent trauma in age more than 12 years only. So for pediatric 0 to 12 years, we do not have ISS valid as of now, but we still are using ISS in those also. So what are the limitation of ISS? All the patient with the same ISS does not mean the same mortality. Suppose an ISS is 17 for all these patients. He has a AIS of 4, 1, and 0. Again, if you scare them, the ISS will be 17. A patient having a AIS of 3, 2, 2, he is also will, if you will submit them, the ISS will be 17. And for these patients, the mortality was different for 410 than 322. If you see, if one injury is very severe, then the chance of mortality increase vis-a-vis he is having multiple injury of smaller intensities. Again, for all patients with same AIS mortality, like if the mortality is almost same, it does not mean they have the same kind of AIS scoring system. Suppose that for head and neck, the mortality is 17%. Okay. Again, all trauma related death does not mean that AS 75 of AS 6. This is what I have explained you earlier. It is not designed to predict disability or outcome. So it cannot predict how much disability will be there. It is only to give you the mortality indicator, not the outcome in terms of how much disability patient will have. So for disability, we have to use a different scoring system. It is costly. It is time consuming. It requires training, because until you are specifically trained into calculating AIS, you cannot give proper ISS. It requires training for capturing the data and calculation of score. It underestimates the mortality result from multiple injuries to a single body result. If single body injury is severely injured, then mortality outcome are better using ISS score. But if multiple body region are injured, then it usually underestimates the mortality. To overcome this part, that it is underestimating a multiple injury patient, we have developed two new scoring systems. One is the anatomical profile score, another is the new injury severity score. So what is anatomical profile score? Before telling you about anatomical profile score, we will tell you about what is new injury severity score. This is also very similar to ISS. This is also sum of square of 3 highest AIS region. So the difference between the difference between injury severity score and the new injury score is that injury severity score used one injury from each body region. Either of 6 body region, you can only take one injury only. But in new injury severity score, you have to take 3 injury again, but from one body region, you can pick up 1, 2, or 3, whatever maximum injury is occurred. So again, coming back to our same example, which I told you in this, suppose a young patient is having EDH and SDH, and he is having abdominal pelvic content injury of spleen injury, and he's having extremity injury of fibula fracture. So his ISS will be 4 square plus 3 square plus 2 square, and it will be 29, the injury severity score. But if we calculate new injury severity score for this particular patient, his head injury is having two severe injury. One is the EDH, which is a score of 4. Again, second is the SDH, which is a score of 3. And his abdominal cavity injury 3 and extremity injury 2. So in this new injury severity score, we will use score of 4, 3, and 3. The score will be 4 square 16 plus 3 square 9 plus 3 square 9. So maximum 3 injury we are taking, and from one body region we are picking 2 injury. So 16 plus 9 plus 9, it will be 18 plus 25. 18 plus 16, so the injury will be 34. So for same particular patient, the ISS will be 29, but the NISS will be 34. So this for 34 give you more, will help you predicting mortality better, as published by few of the recent studies compared to ISS. So this is NISS, that is new injury severity. Okay, NISS and anatomical profile score predict mortality better than ISS, especially in head injury and higher injury severity pattern. Regardless of the scoring, a patient worst injury predict survival best, and accounting of multiple injury important for morbidity and length of stay and disability. Then anatomical profile score, it is a modification of AIS and ISS again. In this, the body is divided into, instead of 6 regions, the body is divided into 4 different regions, which includes brain and spinal cord, thorax and neck, and all other serious injury and all other non-serious injury. So these are the 4 regions they have divided the body. Summation of score for each region is calculated as square root of sum of square of all AIS, as we have done. So in this, we will be calculating for every region square will be done. For brain and spinal cord, 1 injury score square, then for thoracic and neck, then all serious injury, and all other non-serious injury you will calculate square for each, and then you will add them within the each region. These summation of each region are used to calculate ISS. And then modified anatomical profile score is one where only AS more than 3 are used for calculation. For any injury which is less than 3, AS less than 3 is not used. And AP used an anatomical like this anatomical profile is used in one of the combined score, which is known as Ascot score. And another score which I told you was the TRIS score. In this, the anatomical body region score was used as ISS. Okay, I hope you have understood. This was the theory, and then we'll move for 5 practical examples, like how you have to give injury, like how you have to grade each injuries, how you have to grade. Okay, so I have a PDF for that, in which I have written for each injury how much score we are going to give. So I will just share with you that PDF now. Just for iPhone. So okay. So this I have already explained. So this is it visible? Can somebody confirm, please? Hello.
Yes, sir, it's visible, sir.
Okay, thank you. For tibia, I'm just going to elaborate what common injury we are encountering in our day-to-day trauma patient, and then I will tell you how to give injury to like how to give AS score for that, and then obviously you can calculate ISS or NISS, depending upon how, if you know the AS score of these. So for tibia fracture, if the fracture is open, then you have to give a score of 3. If the tibia fracture is closed, then the score given is 2. For femur, if it is open, then the score is 3, and if it is closed, again the score is 3. So for both open and closed, the score is 3, and it does not change with neck fracture, shaft fracture, or the distal femur fracture. The score is always 3 for this patient. Then for fibula fracture, if the score is open, like the fibula fracture is open, then the score is 3. If the fibula fracture is closed, then the score is 2. For acetabulum, if it is open, the score given is 3. If it is closed, then the score given is 2. For humerus, radius, and ulna, all these 3, if the score is open, then the score given is 3. If it is closed injury, the score is 2. For patella, the score given is 2, both open and closed. For pelvis injuries, if the injury there is no SIJ junction disruption, or then the score given is 2. But if there is SIJ disruption, then the score given is 3. If the pelvis injury is associated with moderate blood loss, which is less than 20%, the score given is 4. And if it is 20 or less than 20%, and if it is pelvic injury is associated with very severe blood loss, like more than 20%, or the pelvis fracture is open pelvic book fracture, then the score given is 5. So this is the first case we are encountering an injury score of 5. Coming to common machine cut injury, which you are having in plastic patient, if fingers are injured, even 1 finger, 2 finger, 3 finger, or all 4 fingers are injured, then the score given is 1 only. If thumb is avulsed, except for the thumb, the injury AS score is 2. For wrist and above injury, like if there is wrist cut injury or forearm injury, cut injury are there, and tendon are injured, then the score given is 2. But if the wrist and above towards your like fingers, for forearm and arm, if cut injury is there, then the score given is 3. For traumatic amputation or crush injuries, if it is below ankle amputation or crush injuries, the score given is 2. If it is below knee injury, between ankle to your knee, then the score given is 3. And if it is above knee, then the score given is 4. Then for compartment syndrome, both for upper limb and lower limb, if the arm, lower limb like thigh or leg, and upper limb, the arm, if there is muscle loss, with muscle loss, the score is 3. Without muscle loss, the score is 2. But for upper limb, forearm, the score given is 2. Then for degloving, if there is degloving of entire limb, both upper limb or lower limb, then the maximum AS given is 3. And if the part of limb, like half of the limb is degloved, then the injuries is 2. Coming to head injuries, if there are scalp laceration or scalp defect, if the small injury is there, then the score given is 2. And if defect is more than 25 centimeter square, or the large blood loss has occurred, by which I mean to say 20% or more has occurred, then for scalp laceration defect, the score given is 3. For EDH and SDH, if the patient is non-operative and it is thin, so thickness, if in the CT is 0.6 centimeter, for EDH, the score is 2 if it is non-operative. For SDH, the score is 3. If this was for non-operative, if the EDH, and it is divided into 3 parts: non-operative, small, and large. For non-operative is less than 0.6, EDS 2, SDS 3. For small we mean if it is 0.6 to 1 centimeter in CCCT, or the total volume is less than 50 cc if the child is more than 10 years, and if it is less than 25 cc for the child less than 10 years. See, AES scoring is given for pediatric patient, but ISS, if you calculate square and sum them, ISS mortality prediction is not appropriate. Like you can give the scoring to pediatric patient less than 12 also, but mortality predictor will not be good. That's why I'm telling you. For adult patient more than 10, the 50 cc or less than 50 cc. For pediatric, less than 25 cc. If it come into, these all come into small category EDH or SDH, the score given is 4. And if it is large EDH or large SDH, which means we say the NCCT thickness is more than 1 centimeter, or the total volume is more than 50 cc for 10 years and more than 25 cc for less than 10 years, the score given is 5. Coming to contusions, if the diameter is less than 1 centimeter, it is 2. If the diameter is 1 to 4 centimeter and the midline shift is less than 5 centimeter, the score given is 3. If the diameter is more than 4 centimeter and the midline shift is more than 5 centimeter, the score given is 4. And if the container is very massive, which means the volume is more than 50 cc, the score given is 5. You see, as of now, I have not told you any injury which is having a severity of 6. Coming to skull fracture, if it is a simple fracture, the score is 2. If it is depressed, communicated with intact durometer, the score is 3. But if there is any CS otoria, rhinoria, like cerebral thrombus is fractured, or the skull fracture, the temporal bone has fractured, and the CSF lesion, then the score given is 3. And if it is complex with open durometer, like breast fractures, the score given is 4. Coming to spinal cord injury, if it is transient. So spinal cord injury, I hope you remember what is the injury severity score we use. So ASIA score which we are using, ASIA abbreviated score of spinal injury, ASIA score which we are using. And if it is coming to transient, then the spinal cord injury score is 2. If it is coming to incomplete, then the score is 4. And if it is complete, if the injury is C4 and below, then the score is 5. But if the injury is C3 and above, for complete spinal cord injury, this is the only 6 injury which I have told you as of now. So this is non-survival with life. But still we know if you keep this patient on ventilator, he can survive on ventilator only. So every injury, every score of 6 or a maximum ISS of 75 does not mean patient will die. And every patient who has died does not mean that he had an injury severity of 75. This is again to emphasize. Coming to vertebra fracture, if there is breast fracture, the score is 3. If the odontoid is fracture, so they have not sub-classified odontoid fracture. Like we have 3 class of odontoid fracture. Odontoid fracture 1, 2, and 3, where only the tip is injured or the base is injured, or if there is for all odontoid fracture, for vertebral fracture, the score given is 3. For atlantoaxial dislocation, the score given is 3. For fracture of anterior element, like we have for vertebral body, we have anterior element and posterior element. So again, the body part from the anterior element, if injury is there, then 2. And if it's the posterior element, like we have spinous process injury or lamina is injured, then the fracture is given score of 1. Coming to facial fractures, like Lefort 1 is given a score of 2, Lefort 2 given score of 2, and Lefort 3 is given a score of 3. And if it is associated with more than 20% blood volume loss, then the score is 4. Coming to skin laceration, if it is minor injury, the score less than 25 centimeter square, the score is 1. For major laceration, which is more than 25 centimeter square area, is 2. If severe blood loss more than 20%, then score is 3. Coming to blood vessels, if any blood like artery injury has occurred, suppose femoral artery injury has occurred, or abdominal aorta has injured, or your iliac vessels has injured, if the blood loss is more than 20%, then the score is 3. Otherwise, if the score is no, for brachial and axillary vessel, whatever the blood loss, the injury is given is 2. For smaller vessel like radial, ulnar, cephalic, and basic vein, the injury is 1. Even the femoral, distal, popliteal vessels, all these come into 2. Coming to nerve injury, if the nerve injury is associated with motor loss, then the score given is 2. But if it is without, only sensory loss has occurred, then the score is 1. Coming to joint injuries, if the joint is open, suppose we have a open elbow joint, then the score given is 2. If we have a closed joint, suppose closed knee joint, PCL injury has occurred, then the score is 1 only. For hemothorax, if it is minor, then score is 3. If it is major, defined by blood loss more than 20 or less than 20. If it is major, score is 4. For pneumothorax, if it is minor, then 2. For major is 4. If more major is when more than 50% of lung has collapsed in the X-ray, or there is persistently more than 24 hours, 48 hours. So this is the PDF which I have generated from what I was telling you about a book which we have with us. And if you want to gain more insight, you can attend the AM courses, and it is quite very costly course. It costed me around 75,000 just to get these values, exact values. So this is I'm giving from those only. So this is you can present at any international forum that this score will be valid. If we can have few of the example, suppose like now you can unmute those who are properly listening and can answer. Just we have 2 or 3 example. Just I will write in this only. We have femur fracture, one patient. Then he had fibula fracture. Then he had an EDH. Skin laceration over face. Which is area is less than 25 centimeter square. Suppose this is a young patient who has these injuries. So anybody of you can, I will just write whatever you will tell me. What is the AI score for this patient? What is the score for femur fracture? Anybody can tell.
Sir, 3.
3. Okay. Fibula fracture.
Sir, yes, 2.
Sorry.
Sir, 2.
2. Good. Suppose the EDH is non-operative. I'll just mention. Non-operative EDH. 0.7 mm thickness. Score. Anybody? Just guess is okay. This is just text. You don't have to remember. I will share this PDF with you. Suppose if you're not remembering, this is just to tell you that how do we actually calculate this score. So a small EDH of 0.7, the score is 4. Okay, adult patient, obviously. Suppose for this we have given a score of 4. And skin laceration less than 25 centimeter square. So what is the score? Anybody? Okay, I will just show you. If you don't, skin laceration less than 25 centimeter, what is the score? Hey, this is in front of you. What is the score? Come on, please participate. Otherwise,
1.
1. Okay, good. So score is 1. Okay. Now the question is, what will be NISS score for this particular patient? This you have to answer. Anybody? Who is going to answer? Just me check. Whoever, anybody can answer. Chandni, you there? Or who is there? Who else is there? Yukti, are you listening?
Yes, sir.
Okay.
Sir, we'll take EDH का 4 का square 16 plus fibula का fracture 4 plus femur fracture 9.
Fibula ka fracture 4 plus?
Sir, femur का fracture 9.
9.
29.
So it will be 29. Jivan, what will be ISS score for this patient?
Sir, in ISS, we cannot take fibula fracture. We'll have to take only EDH, femur, and skin laceration, which will lead, it will give to
16 plus?
9 plus 25, 26.
No.
26, sir.
You are
16
taking
plus
EDH?
9 plus 1, sir.
9
I'm
plus?
taking EDH, femur fracture, and skin laceration.
Okay.
Once.
Okay. The score will be, this is 26. I hope you got the point. Okay. Again, just changing the example. Okay. This was good. Again, 2-3 example we will do like this and then we will close off. Okay. Suppose he is having femur fracture, EDH, and he is having SDH, which is more than 25, more than 50 cc, and he is having injury skin lacer more than this, so I will delete this, and he's having a odontoid okay, just forget all the odontoid fracture. He's having C3 fracture with C3 fracture anterior alignment and he is having spinal cord injury, ASIA A, which means obviously you know the complete injury. Okay, again, femur, what will the score for SDH?
Sir, SDH it's 5, sir.
Okay, we'll just go and confirm whether it is 5 or not, because this text you will have with you. So it is 5. Okay. It is just to teach you that you should understand how you are scoring each and every injury. Like this is how you have to score each and every injury. Then you have to calculate the score for C3 fracture anterior element. If anybody can tell, or I will just go back. Okay, now tell me. C3 anterior element. What is the score? Anybody? Come on, yeah, please participate. Otherwise, there is no point of doing these discussions.
4.
Who is this? Nirav?
Yes, sir.
Nirav, see, I'm just telling you C3 is the vertebra injury. So you have to calculate from vertebra, not the spinal cord injury. Okay.
Okay.
So C3 anterior element fracture is 2. Okay. And along with C3 fracture injury, he has spinal cord injury at, because the fracture was there and he has descended at C3 level, spinal cord injury at C3 level. And the ASIA classification is 1. Then what is the score for this? What is the score now? C3 spinal ASIA A.
Sir, 6.
86. Okay. Now tell me, what is NISS for this patient and what is ISS for this patient? Any GR? Anybody can tell, please. This is the last example we are having, maybe. Anybody still there or all have left? Jivan, you there? Nirav?
Sir, for NISS, we'll take spinal injury 6 square
6 square,
plus
36.
plus we'll take EDH, sorry, SDH, that is 5 square, sir.
25.
Plus we'll take EDH, that is 4 square, sir.
4 square.
75.
What is total?
Sir, ultimately it'll have to come to 75 because 36 is there in one segment. If it's 36, then we'll take the total as 75 anyway. Sir.
So you don't have to calculate this. This is what
Yes, sir.
important. So the score is 75. And what is the ISS?
Sir, in ISS we will take ISS also will come to 75, sir.
Yes,
75.
ISS is also 75 for this patient. Okay. I hope you got the point. Now, suppose I remove this part. Now what will the NISS? One by one, come on.
As for SDH, square of 5.
Square of 5 is 25. Okay.
For femur fracture, square of 3.
Square fracture, femur 9. Okay.
And C3 fracture,
C3 fracture,
square of 2.
square of 2. So it will be 4. This is how much it will? 9 plus 4, 38. Who is this? May I know the name? Karan. Okay.
Yes.
Karan, anybody disagree with this? Okay.
Sir, why
Next,
not take
what is the
EDH and
ISS?
SDH?
Okay.
Sir, in
I will tell you.
NISS we'll have to take SDH and EDH separately, sir. So it will be 25
So
plus
it will be
16.
5 square plus 4 square. So it will be 14.
No, 16 plus 9.
9. So this will be the exact, Karan. Here you have missed it. Okay, so the score will be 50. Now
Yes,
coming. What is the ISS of this patient? Again, Karan, come on.
That was ISS, sir.
Now tell me again.
Okay. SDH, sir, 5 square.
5 square 25.
And femur fracture, 3 square.
9.
And C3 fracture, 2 square.
C3 fracture 4. So this is 9 plus 38. Anybody disagree with this? Revati?
Sir, C3 comes in head and neck
Yes, very good.
already, sir. So we cannot
So
take
you
two
cannot
square
take
again.
C. You cannot take this 4. Very good, very good. So what will come here?
Sir, it will be 2 square for skin
Skin
laceration greater
laceration
than
we can add.
25, sir.
Yes, very good. 2 square for listeners, but the score is again 38. Okay, correct. The score has not changed, but how you have to calculate the mechanism has changed. Okay, now again in this same example, I remove this part. Now tell me what is the ISS. ISS will be same. Okay, it will not change because we have 3 maximum, again the same. What will the ISS of this patient? Anybody? Come on, Karan. Any idea? Will this be same or something different? Revati?
It should be same.
We have to include EDH and femur fracture for sure. And
EDH? No, the score is 4, na? SDH you are telling, right?
SDH, sorry, SDH and femur fracture.
Okay. What will the ISS tell me? ISS will be same because we have maximum 3 injuries, so it will be same. What will the ISS? This is a little tricky. That's why I'm focusing so much. Anybody can tell what is the ISS? Come on here. Revati, you there? Any Bisman? Anybody there? Anybody else? Nirav? Yukti? Come on, this is the last. When will you? Hello. Karan?
Femur and SDH only.
Sorry, Nirav, huh?
Femur and SDH.
Femur and SDH. So the score will be
34.
34 only. We are having 2 only, na? Only 2 body system are injured. So ISS can be taken 1 from each only. So the score will be 34 in this. Okay. So this is how we calculate IS and ISS. And I will be sharing this PDF, like whenever you are coming to trauma OT or ICU, I will be sharing this, and then you can appropriately calculate the scores. Okay. Now we log. Thank you all.
Yes.
Thank you.
Thank you, sir.
Yes, sir.